Welcome to the deep dive, everybody. I'm so glad you're here today because we are tackling a topic that has just an immense amount of cultural baggage.
Oh, absolutely. Tons of baggage.
Right. I mean, for centuries, this idea of a quote-unquote loose vagina has been used as like a cultural weapon, basically to shame sexually active women.
Yeah.
And it is a trope so persistent that, millions of people just assume their bodies permanently stretch out over time from intimacy.
Yeah, they treat it like an absolute given.
Exactly. But if we put the playground rumors aside for a minute and actually look at the biomechanics of the human body, that concept is an absolute biological myth.
It really is.
So today on the deep dive, we are taking a massive stack of clinical guidelines, gynecological studies, and pelvic floor physiotherapy resources. And we're going to look purely at the biological, anatomical, and physiological facts to answer one fundamental question. Can frequent sex cause vaginal laxity?
And, the short answer and the clinically accurate answer is no, it doesn't. Our mission today is to strip away all that cultural stigma and look at the actual physics of the pelvic floor. Because when you understand how this tissue is designed to function, you realize that the number of partners or the frequency of penetrative sex, it just does not affect the baseline shape, size, or the structural integrity of the vaginal canal.
Which is, that's a huge paradigm shift for anyone who has absorbed the cultural messaging around this.
Yeah.
Okay, let's unpack this, because if the biology tells us that frequent sex doesn't cause looseness, we have to address the obvious question. Why do people swear that the physical sensation, like the actual feeling of tightness, changes during different sexual encounters? Are they just, misinterpreting what they're feeling?
Well, no, they aren't misinterpreting the physical sensation itself, but they are entirely misattributing the cause.
Okay, how so?
The physical feeling of tightness or looseness during sex is intrinsically tied to the neurological and vascular state of arousal. It's not about, structural wear and tear from over the years.
Right, it's not a pair of cheap sweatpants that just lose their shape after a few wears.
Exactly, that's a great way to put it. It's much more like an accordion or a highly advanced memory foam. When a person is fully aroused, the body undergoes a process called vasocongestion.
Which is blood flow, right?
Yes, exactly. Blood flow increases to the pelvic region. And in response to that, the vaginal muscles naturally relax, the vaginal canal actually elongates physically, and the tissues self-lubricate.
So it biologically changes shape to become more accommodating.
Precisely. The space naturally opens up, which makes it feel less constricted, and that is the biological system working optimally.
Wow.
On the flip side, though, if a person is anxious or experiencing pain or simply, not fully turned on, those vaginal muscles involuntarily spasm. They tense up.
And I imagine that's where the massive misunderstanding comes in.
Yeah.
Because society has essentially branded a quote-unquote tight vagina as a badge of youth or optimal health, when clinically what you're describing sounds like it's literally a symptom of tension.
In a lot of cases it is. In extreme clinical cases, involuntary muscle spasms can lead to a condition called vaginismus.
Right, I've heard of that.
Yeah, and that's where the muscles clench so tightly that penetration becomes incredibly painful or just completely impossible. So when someone equates extreme tightness with a healthy state, they're often unknowingly celebrating a lack of arousal or even a pain response.
That is wild to think about. So if everyday mechanical use frequent sex isn't what changes the structure of this tissue over time, what actually does possess the physical force to alter it? Because people do, they experience legitimate, permanent changes to their pelvic anatomy.
They absolutely do. And to understand the forces that actually alter the anatomy, we have to look at what the clinical literature calls the musculoelastic hypothesis.
Okay.
The vagina isn't just an isolated tube floating in the body, right? It relies on a really complex support system.
And how does that system actually work? Because I always hear terms like pelvic floor, but it is so hard to visualize what is physically holding everything in place in there.
Sure, well, think of it less like an empty, rigid tube and much more like a trampoline bed.
Oh, a trampoline. Okay.
Yeah, so the vaginal canal is the fabric of the trampoline. But underneath and surrounding it, you have this network of muscles, specifically the levator ani-muscle group and fibromuscular connective tissue called the endopelvic fascia.
So they act like the springs.
Exactly. These muscles act like the heavy-duty springs holding the fabric taut from the outside. They attach to the pelvic sidewalls, and they keep the organs supported.
So if you stretch the fabric a little bit, the springs just pull it right back.
Yes, that's its normal elastic function. The tissue is remarkably resilient, but that brings us to the first major culprit of permanent structural change, which is childbirth.
Right. Because pushing an 8-pound baby out is a physical event that demands a massive, sudden stretching of those springs.
It requires the levator ani muscles and the surrounding fascia to stretch far, far beyond their normal resting state. And look, in an uncomplicated delivery, the body usually recovers.
But not always.
No, not always. The clinical sources highlight very specific risk factors that can cause lasting trauma. Multiple vaginal births, delivering a baby over 8.5 pounds, or needing a forceps delivery. Those dramatically increase the risk of physically tearing those muscles.
But wait, muscles usually heal, right? Like, if you tear a muscle in your leg, it repairs itself eventually. Why does trauma to the pelvic floor result in this chronic, permanent loss of tension?
That is where the specific biomechanics of delivery come into play. Because we aren't just talking about muscle tears. The medical sources detail a phenomenon called neurogenic muscle damage.
Meaning damage to the nerves themselves.
Yes, exactly. Nerves run all throughout the pelvic cavity. So during a prolonged or really difficult delivery, as the tissue is stretched to its absolute limit, the nerves supplying the pelvic floor are stretched like rubber bands.
Oh, wow.
Yeah. And if a nerve is stretched too far, the fibers get damaged. When a nerve loses its ability to send a strong signal, the muscle it controls begins to atrophy. It weakens.
Right, so the trampoline springs lose their tension because the neurological signal telling them to stay tight has just been compromised.
Precisely. You can't maintain baseline tone if the electrical signal is broken.
That makes total sense. Okay, so that covers the trauma side of the equation. But what about the passage of time? Because the sources go into heavy, heavy detail about aging. Specifically, a condition called genitourinary syndrome of menopause, or GSM.
Right, GSM, menopause, introduces a systemic chemical shift. And the defining characteristic is a dramatic drop in estrogen.
Which is super important for this tissue.
It's vital. Estrogen is essentially the fuel that maintains the structural integrity of the pelvic tissues. When estrogen levels plummet, the mucosal layer of the vagina thins out. The sources indicate that estrogen deficiency actually leaves a woman with less than 10% of superficial epithelial cells.
Wait, I want to stop there for a second. When you say superficial epithelial cells, we're talking about the outermost protective layer of the tissue, right?
Correct. It's the surface lining that acts as a barrier and provides thickness and lubrication. So when 90% of that layer just vanishes, the tissue becomes incredibly fragile.
Man.
But the structural breakdown goes much, much deeper than the surface.
And this is where the notes absolutely blew my mind, specifically the chemical cascade that happens to the vaginal microbiome. I mean, if you're listening and you have navigated these symptoms, you know how incredibly frustrating it is to deal with chronic irritation and just be told, oh, it's normal aging. But there is a massive chemical war happening on a microscopic level.
It's a profound shift in the local ecosystem. So in a healthy estrogen-rich environment, the vaginal cells shed regularly and they release a sugar called glycogen. And glycogen is the primary food source for lactobacilli.
And lactobacilli are the quote-unquote good bacteria.
They are. They produce lactic acid, which keeps the vaginal environment acidic. That acidity is a built-in defense mechanism against infection. But when estrogen drops during menopause, the glycogen production just stops.
So without food, the good bacteria literally starve.
They die off, yes.
And when the good bacteria die, the pH level spikes.
The environment becomes much more alkaline, yes.
To put that pH shift in perspective for you, a healthy vaginal pH is naturally acidic, somewhere between 3.5 and 4.5. It's roughly the acidity of a tomato.
Right.
But without estrogen, it becomes more alkaline, rising above 5, which is closer to the pH of pure water or blood. And that might sound completely harmless, but for that specific bacterial microbiome, it's like suddenly changing the water in a saltwater fish tank to fresh water. The good bacteria simply cannot survive that environmental shift.
That is an excellent way to conceptualize it. And without that acidic protection, the body faces a cascade of physical problems. Chronic dryness, severe burning sensations, micro-tearing during intimacy, and a dramatically increased risk of urinary tract infections.
And the tissue loses its chemical protection, but it also loses its physical bounce, right?
Yeah.
Because I was reading this section on collagen, and the text mentioned that the existing collagen fibers, quote, hyalinize. Wait, hyalinize, is that like turning into glass?
That is exactly what it means. Deep in the connective tissue, you have cells called fibroblasts that produce collagen and elastin, the proteins that give the vagina its stretch. Post-menopause, those fibroblasts become dormant. The existing collagen fibers hyalinize. They become stiff, glassy, and fuse together.
Oh, wow.
Yeah, and the elastin fibers literally fragment. The tissue physically loses its mechanical ability to stretch and rebound.
So if you are listening to this, you might be dealing with muscle and nerve damage from childbirth, or you might be experiencing a chemical and structural breakdown of the tissue itself from menopause, or honestly, sometimes both, which leads to a massive diagnostic problem. Because if the brain is feeling a symptom, how do you decipher what is actually failing? Treating the wrong issue seems like it could just make everything worse.
It absolutely can. That's the greatest danger of self-diagnosing or relying on, internet forums when you experience a vague symptom like looseness. Clinically, a physician has to differentiate between a subjective feeling and a true structural failure.
Break that down for us. What is the actual difference between laxity and a structural failure?
Well, vaginal laxity is categorized as the subjective feeling of looseness and a reduction in physical sensation during intimacy. It's a symptom. On the other hand, you have pelvic organ prolapse, which is an anatomical diagnosis.
Prolapse is when the trampoline springs completely give out.
Essentially, yes. Prolapse is a structural failure where the levator ani muscles can no longer hold the pelvic organs up against gravity. The bladder, the rectum, or the uterus can literally sag downwards and press into the vaginal canal.
Yikes.
Yeah, this creates a visible bulge and a sensation of heavy downward pressure, often described as a feeling of things just falling out.
But here is a detail from the diagnostic protocols that really challenged my understanding. Sometimes what a patient is absolutely convinced is looseness has nothing to do with muscle weakness or prolapse at all.
Right, and what's fascinating here is that this is where we return to the nervous system. We talked earlier about pudendal nerve injury during childbirth, that severe stretch injury to the nerves.
Yes, the compromised electrical signal.
Well, sometimes that nerve damage doesn't just weaken the muscle. It causes a profound loss of sensory perception. It causes numbness.
So the brain gets completely confused by the lack of input.
Exactly. The brain relies heavily on physical friction and pressure to register sensation during intimacy. If the local nerves are damaged and they cannot transmit those sensory signals up to the brain interprets that lack of feeling as a lack of physical friction.
And it translates a lack of friction as looseness.
Precisely. The pelvic floor muscles themselves might be perfectly tight and functioning well, but because the sensory tissue is numb, the patient's brain assumes the physical space must be too large.
That neurological illusion is just staggering. It explains why someone might feel loose, even if their anatomy hasn't physically changed shape at all.
Huh.
And it perfectly highlights why you can't just buy a random tightening cream off an Instagram ad.
Yeah, definitely not.
You need a clinician to test your reflexes to see if you are dealing with a muscle issue, a hormone issue, or a severed nerve. Which naturally brings us to the treatments. If a listener goes to a specialist and they get an accurate anatomical diagnosis, what are the actual science-backed ways to resolve these issues? Let's start with the muscles.
Sure. So if the clinical diagnosis is postpartum muscle weakness, the absolute gold standard, the first line of defense, is pelvic floor physical therapy. This involves targeted exercises using biofeedback, vaginal weights, and working with a specialized physiotherapist.
To be clear, we're talking about Kegels and similar resistance training. But I really want to unpack the actual mechanism here, because I think a lot of people assume doing a Kegel is like pulling a drawstring, and it somehow shrinks the vaginal canal itself.
That is a very common misconception. The vaginal canal itself is just the mucosal fabric, remember. It does not shrink from exercise. When you engage in pelvic floor physical therapy, you are focusing entirely on the levator ani muscles that surround the outside of the canal.
So how does strengthening an outside muscle make the inside feel tighter?
It's the mechanism of muscle hypertrophy. Think about when you do a bicep curl with a heavy weight. The muscle fiber tears microscopically and rebuilds thicker and denser. It gains mass.
Right.
When you apply that same resistance principle to the pelvic floor, those muscles hypertrophy. Because they form a ring around the vaginal canal, that extra bulkier muscle mass literally presses inward.
Oh, so it physically narrows the space from the outside in.
Exactly. It creates a tighter structural grip, and more importantly, it provides a significantly stronger, thicker shelf to support the organs and prevent prolapse. And the clinical data supports this heavily. Structured pelvic floor physiotherapy dramatically decreases the risk of experiencing prolonged looseness after childbirth.
But if the diagnosis isn't muscle weakness-like, if the brain thinks things are loose because the tissue is numb, dry, and breaking down from genitourinary syndrome of menopause physical therapy can't fix a chemical deficit.
No, it cannot. If the fibroblasts are dormant and the glycogen is gone, you require hormonal intervention to reverse the tissue atrophy.
The sources outline a few localized treatments for this, like low-dose vaginal estrogen creams and small inserts. There's also an oral medication mentioned, ospemifene, which isn't estrogen but binds to estrogen receptors specifically in the vaginal tissue to trick it into rebuilding.
Right.
But I want to focus intensely on one specific treatment detailed in the British Menopause Society consensus statement. It uses DHEA, which is also known as prasterone.
Ah, DHEA is a fascinating intervention. It's a precursor hormone, meaning it's a building block naturally produced by the adrenal glands and the ovaries.
Hold on, though. The vaginal wall is incredibly porous. That's why so many medications are administered transvaginally. They absorb straight into the bloodstream.
Yeah.
If you give someone a daily dose of a precursor hormone like DHEA, how can we be sure it isn't just leaking into the systemic bloodstream and causing a massive spike in testosterone everywhere else in the body?
That is an extremely logical biological challenge. If you applied it elsewhere, systemic absorption would be a primary concern. But this therapy relies on a highly specialized cellular mechanism known as intracrinology.
Intracrinology. Okay, explain that. How does that stop the hormone from going systemic?
When DHEA is delivered locally into the vagina via a daily pessary insert, it doesn't just passively seep into the bloodstream, it's absorbed directly into the vaginal epithelial cells. Inside those specific cells, there are localized enzymes.
Okay.
Those enzymes grab the DHEA and convert it directly into active estrogen and active testosterone inside the cell itself.
So it manufactures the active hormones locally, right where they are needed.
Yes. The new estrogen thickens the mucosal layer, and the local testosterone stimulates the deep nerve endings and rebuilds the collagen density. And here is the mechanism that answers your concern about systemic leakage. Because this conversion happens internally at the cellular level, the hormones are utilized and then deactivated right there at the site of synthesis.
They never make it out of the cell to circulate.
Exactly. Over 95% of those active hormones stay strictly within the vaginal tissue. They do not enter the systemic bloodstream in any clinically significant amounts. It allows a patient to completely reverse localized tissue atrophy without risking full-body hormonal side effects.
That is such an elegant biological solution. So we have hypertrophy for the muscles and intracrinology for the tissue. But we have to address the elephant in the room regarding treatments.
I think I know where you're going with this.
Yeah. If you spend 5 minutes online searching for solutions to vaginal laxity, you will immediately be bombarded with heavy marketing for quote-unquote vaginal rejuvenation. These are private clinics using high-powered lasers and radiofrequency devices, claiming they can painlessly restore your collagen in a 5-minute lunch break procedure. Here's where it gets really interesting.
Yes, energy-based devices, like fractional CO2 lasers and erbium lasers, they are indeed heavily marketed to vulnerable patients right now.
What is the actual science behind pointing a laser at the vaginal wall?
Well, the underlying theory is thermal damage. The laser beam is calibrated to target the residual water molecules inside the vaginal connective tissue. The thermal energy essentially boils those microscopic water droplets, creating controlled microscopic burns deep in the tissue.
And the body registers the burn and rushes blood and resources to heal it.
That's the intended mechanism, yes. The microscopic damage produces acute edema, or swelling, which theoretically plumps the tissue in the short term. As the body mounts a healing response to the burn, it stimulates the dormant fibroblasts to lay down new collagen and form new microscopic blood vessels.
I mean, it sounds somewhat plausible in theory, and the sources do note that some small studies suggest it can temporarily increase lubrication for women who absolutely strictly cannot use localized hormones like certain cancer survivors.
Right.
But the broader medical community seems incredibly alarmed by this trend.
They are urging extreme caution. The UK's NICE guidelines, that's the National Institute for Health and Care Excellence, have formally restricted the use of these transvaginal lasers strictly to research purposes at this time. They are not approved as a standard clinical treatment for laxity or atrophy.
Why the restriction? Is it just a lack of long-term data?
It's a lack of long-term safety data combined with a very real documented potential for severe complications. We are talking about applying indiscriminate thermal energy to highly delicate, hormonally starved mucosa.
And to really drive home why applying unregulated thermal energy to your internal organs is a massive risk, there's a specific, really harrowing case study highlighted in the clinical overview.
Yes, there is. It involves a 65-year-old postmenopausal woman. She was a breast cancer survivor, so she had completely discontinued systemic estrogen therapies due to oncological safety concerns. Because she was suffering from severe vaginal dryness and atrophy, she sought out a private clinic and underwent 3 separate laser treatment sessions.
And a few weeks after her final laser session, she attempted to resume penetrative intercourse.
And she immediately suffered heavy vaginal bleeding. When doctors evaluated her in the operating room under anesthesia, they discovered severe, deep lacerations across the vaginal walls that required surgical suturing to repair.
Oh, wow. So the tissue was so compromised from the thermal burns that it just tore open.
It did.
But the trauma didn't end with the lacerations, did it?
No. Several months later, the patient returned to the clinic experiencing intractable pain and an absolute inability to engage in intimacy of any kind.
What happened inside the tissue?
The localized thermal damage from the lasers had triggered a catastrophic healing response. Her body overcompensated for the burns by laying down massive amounts of thick, unyielding fibrotic scar tissue. Her vaginal canal had scarred down entirely, foreshortening to a total length of only 2.5 centimeters.
2.5 centimeters. I mean, that is permanent, life-altering structural devastation from a procedure that was likely marketed to her as a quick cosmetic fix.
That's awful.
And it perfectly highlights the danger of unregulated markets capitalizing on patients who feel dismissed by traditional medicine.
It underscores a crucial point. When patients feel embarrassed by symptoms of laxity, or when they are told that pain is just a normal part of aging, they retreat from clinical guidance. They turn to quick fixes. But accurate knowledge of the underlying biology is profoundly protective.
It's the difference between true healing and permanent damage. So bringing this massive diagnostic landscape together for you listening, we've taken a hard look at the biomechanics today. We've established definitively that a loose vagina is a cultural myth. It is not a byproduct of a healthy, active sex life. The true forces that physically and chemically alter vaginal elasticity are the immense mechanical stretching and nerve trauma of childbirth and the natural biological estrogen drop of menopause that literally starves the cellular microbiome.
And by understanding those mechanics, you gain agency. Whether your solution requires engaging in targeted pelvic floor physical therapy to achieve muscle hypertrophy or, utilizing local hormones via endocrinology to rebuild your collagen, there are precise science-backed paths forward. You never have to accept a loss of physical sensation, chronic discomfort, or a loss of intimacy as the inevitable price of having children or growing older.
It's about moving out of the shadows of shame and into the light of precision biology. Which leaves us with one final thought to ponder as we wrap up today's deep dive. We started by exploring how deeply our understanding of something as fundamental as vaginal elasticity has been manipulated by shaming folklore for centuries. If a myth that big can dictate how millions of people view their own anatomy, what other areas of our physical health are we still misjudging or completely mistreating simply because we are trusting playground rumors rather than the actual science of our bodies?
That is a question that requires us to constantly reevaluate what we assume to be true about ourselves.
Until next time, keep questioning the assumptions, keep digging into the biology, and always look for the scientific facts beneath the cultural folklore.